Broadcast is now starting. All attendees are in listen-only mode.
Hi, Bill Shaw, Great Plains Laboratory, and I'm going to talk to you about a different plague tonight. You've been hearing so much about coronavirus. So anybody who's signed up for this webinar and thinking it's coronavirus, tonight it's a different plague. And it's a plague that's actually described several pages in the Bible talk about the material that you see on the wall back here. And in the Bible, the English translation is, there are two words that are used, and sometimes the word is plague, and the other word used to describe this stuff on the wall is leprosy. So there's a very long passage in the Bible about what to do if you see this leprosy on the wall of your house. And it suggests that if you see this, you're to contact the rabbi, and the rabbi will examine it, and he will direct you to leave your house for a period of a week. And in the meanwhile, the house will be shut up, and the rabbi will determine if the stuff is growing. And if it's still growing, you have to cut out the part of your house that's contaminated and throw it into the dump. So the material I'll be talking about humans have been dealing with it for probably 4,000 or 5,000 years, and still having probably as much difficulty as they had in biblical times. So the mold that grows on the wall is very toxic, and one of the considerable reasons it's toxic is because of the production of chemicals that are relatively small molecules. Most of them are below a molecular weight of 1,000, whereas, say, a large protein may weigh 200 or 300,000. So compared to a large protein, these are relatively small chemicals, but they're extremely toxic. In some cases, they were used as war weapons in the Middle East. So there are two big sources of these chemicals, and contaminated food can be one of the causes. So the grains are a major source of mold, which produce mycotoxins. There's a large number of these things in the hundreds, but some are more common than others. So food is a very common thing. So wheat, rye, barley, corn. And so breakfast cereals are a common material that may be contaminated with mold and mycotoxins. But by far the most common cause of being exposed to these materials is water damaged buildings. So if you have a bathtub that overflows, if you have an area like Houston where there was huge amounts of flooding due to a hurricane, and this can be a major source of contamination, and so these can continue to be problematic for long periods of time. There's a wonderful segment on forensic files, which usually deals with murder, but in this case, they were a couple had built a $10 million mega mansion, but there was a leak in the water line going to their ice maker, and they called the insurance company and asked the insurance company to fix it. They refused to do it. They said, well, we'll just do it ourselves. And the insurance company says, if you touch anything there before our adjuster comes out, we won't pay you a cent. And so as a consequence, it took about 3 months. And in the 3 months, the mold went from a small area behind the refrigerator to covering virtually the entire house, to the point where it was thought the house would just have to be leveled and start over. So a small amount of mold can become a very large amount of mold if it's not treated. So remediation is extremely important. So whether you're exposed by the diet or by the living in a house, and when I say house, it could also be car, or it could be your office or school that are contaminated, you will have these mycotoxins form in the urine, form in the blood. The blood is filtered and becomes urine, and then the urine can be tested using the mass spectrometer, which is the most elaborate and considered the most accurate way of doing testing. So this shows the what is called a triple quadrupole, and a quadrupole is, you know, the word for four, and poles. So there's 4 poles. There's 3 sets of these 4 poles, and these are all involved in separating fragments of broken down molecules so that you can determine the exact molecular configuration of a molecule. So it's the most accurate way and sensitive way for testing virtually anything. Of course, that's why it's commonly used in drug testing. The mycotoxins, myco meaning mold toxins, are some of the most prevalent toxins in the environment. And they're all produced by fungi, and sometimes it is yeast as well, which is also a member of the fungi family. And it's estimated in the European Union, 20% of all grains have been contaminated with mycotoxins. So there's a very large business in which foods are tested to see if they're contaminated with mycotoxins, and what I suspect is if the food is too contaminated, they'll probably end up giving it to animals. Studies that were on the internet showed that dog food was commonly contaminated with mycotoxins, a very high percentage. And people from one of the companies said that what would happen was when the dog food was expired, it would be sent back to the original company, who would then just take a razor knife, open the bag, and then pour it into a new bag. So the idea of quality was missing, and they found out that even the most expensive dog food had extensive mold contamination. So the LC-MS is very useful. It stands for liquid chromatography and mass spectrometry. The method used at Great Plains, there's an extraction that removes impurities, and so there is some variability in the extraction. To compensate for that, at Great Plains we had heavy atom isotopes. So in other words, if we're using a particular mycotoxin, we'll use an internal standard that has exactly the same chemical constituency as the mycotoxin we're testing, except that it has heavy atoms like C13 or deuterium, heavy hydrogen added to it. So the molecule of the internal standard reacts exactly the same as that of the compound to be measured. And then on top of that, then these chemicals are fractionated. Each of the chemicals will go through what is called a column at different speeds, and the speed of which it travels is a unique characteristic of the particular molecule. And then on top of that, the mass spectrometer breaks down these molecules into fragments, and then the fragment is further broken down into other fragments. And so you're testing the fragment of a fragment of which the extraction has been controlled with heavy isotopes. And so it just means that this is the greatest accuracy that you can get at the present time. These are some of the mycotoxins commonly tested in urine: rhodine, verocarin A, aneatin B, zearalenone, Zea coming from the word corn, mycophenolic acid, ketoglobicin, aflatoxin, Okra Toxins, stigmatocystin, citrinin, and gliotoxin. The mycotoxin that I was familiar with, and that I think many people are, is the aflatoxin, which is a contaminant in peanuts. And peanuts commonly become contaminated because peanuts grow under the ground. And so growing under the ground, they're more subject to mold. And so aflatoxin is a cancer-causing mycotoxin that's commonly tested in not only in peanuts, but also in things like peanut butter or other foods that are commonly associated with aflatoxin. So this shows the current format of the normal ranges, and so what we have here is, so for example, the first one of this is, first you see at the top the word aspergillus. So the chemicals down below are most commonly found in aspergillus. That doesn't mean there might not be formed by other, but it means that the majority or the most common source of these three mycotoxins is aspergillus. The first one you see, it gives results nanograms per gram of creatinine. This is a very important aspect because creatinine checks for variations in the fluid intake. So if you don't have a creatinine correction, which many laboratories reporting mycotoxins don't, you have differences in fluid intake could make huge differences in the interpretation. So you're really could be measuring differences in fluid intake rather than differences in mycotoxins, a very important aspect. And the normal range is given here. So the normal range for aflatoxin would be 3.5 to 20. And the area in which, if somebody had a value in the normal range, it would be inside this green area. But here we have on the next one, Okra Toxin, which is, by the way, the most common mycotoxin that we see. And we see more positives for this than any other mycotoxin. You see the patient's value is 38.95, and the normal range is 4 to 20. No, no, I said that wrong. The 4 to 20 is the range of the common range for sick people. The green area is up to 4. So that means if the value is up to 4, it's in the normal range. If it's higher than 4, it means it's in the abnormal range. So values in the red are values that are found in sick people. So some people have gotten this confused. So If the value is only in the green, it means you don't have to worry about it. But if it extends out of the green into the red, it means it's one to be concerned about. And further on down, you see Penicillium. And Mycophenolic acid is a common metabolite from Penicillium mold. Of course, penicillin comes from Penicillium mold, and that's where the common antibiotic is found. So molds are a major source of different antibiotics. So going to mycophenolic acid, you see the value goes up to, the normal range goes up to 5. The range in sick people is 5 to 50, but this is the typical range. You're going to have some people who have higher values than that. And so this particular person is nearly 84. So when the value goes all the way across the line, the black line, it means this is a substantial value. And even if the value only goes up slightly, it may be causing some grief to the patient. That's where it's more difficult, is the value is very close to the normal limit. Maybe it is, maybe it isn't. That's where the clinical judgment comes in. Here's one of the ones we test, trichothecines, and there is ring structure, and each one of these of the atoms in the ring structure has a particular number, and there's different variety of these and different metabolites of these mycotoxins. Here's one, Roridin E. It's called a macrocyclic trichothecene. And so there's a variety of these compounds called trichothecene, which have similarities, but each one has a unique molecular weight, so they can be differentiated by mass spectrometry. So this particular chemical, Roridin E, can be from mold from water damaged building. It can also be from food mold. It was used, I believe it was the Iran-Iraq war, used by Iran for biological warfare. It can cause neurologic damage, immune suppression, endocrine disruption, and gastrointestinal symptoms. So there is extensive overlap in clinical symptoms. So many people may have multiple different mycotoxins. In addition, the clinical symptoms overlap on these. So the fact that somebody has a particular set of clinical symptoms doesn't necessarily mean it would only be one mycotoxin. It may be several different mycotoxins that are causing similar symptoms. Here's another one, Verrucarin A, symptoms very similar to Roridin E. Stigmatocystin, another mycotoxin. All of these have molecular weight less than 1,000. The stigmatocystin is, again, found in both water-damaged buildings and food. Its structure is very similar to aflatoxins, and like aflatoxins, it can cause cancer. And that's one of the main reasons that foods are tested for these mycotoxins, because if the food is high in these, there's a much higher rate of cancer in people eating these contaminated foods. It's toxic to the liver, kidneys, immune system, and lungs, and it depletes glutathione. Aflatoxin B, so I'm going to go back and forth here. So here's stigmatocystin, and here's aflatoxin B. So you can see the shape of the molecule is very similar between these two mycotoxins. Aflatoxin mainly in food, but even in the ones that are mainly in food, some of them may also be in water-damaged buildings. It's more, for some reason, it's more toxic to children than adults. and the common toxicity is liver, but it can be toxic to many other organs. So it's toxic to the brain, cause mental impairment, abdominal pain, depression of white blood cells, headache, jaundice, and the most common, the Okra Toxin A. So I would say perhaps 60% of all samples we test are positive for Okra Toxin A. Again, food and water damaged buildings, it's nephrotoxin, meaning it's toxic to the kidneys. It can suppress the immune system. Again, most of these chemicals are also carcinogenic, can cause neurologic symptoms, and there have been a number of studies implicating this as one of the causes of Parkinson's disease, and we have some of that data myself. I'm not sure if I have those slides in here, but we've seen a relationship between high Okra toxin and Parkinson's disease. Aneatin is a little bit different in that it's made up of amino acids that are linked together to form a large ring structure. It is a food contaminant. One of the unusual things about it is it can cause extreme weight loss. People who have had this have lost as much as 50 pounds after being exposed to the mold producing this. Can cause fatigue, liver disease, impairs the mitochondrial function, and can alter bone structure. Zearalenone is important because part of the molecule has got similarity to estrogen, and as a result of this, it acts as an anti-estrogen and interferes with endocrine function. It is a potent estrogen itself. It can cause premature puberty, like in young girls, 8 or 9 years old. It can also cause abortions and can impair fertility. And it can even impair fertility in the next generation. So it is extremely toxic in that regard. It can completely cause atrophy of the thymus, which is the organ associated with immunity, and so not surprisingly, it causes immune suppression. There was a case in Texas where a dozen people died after eating corn contaminated with zearalenone. Gliotoxin is a mycotoxin that there's some evidence that it may be produced by candida in addition to molds, and it's controversial at present. Gliotoxin, again, is a very toxic chemical, which a very small amount can be fatal, and it is a marked, it is a chemical that causes marked impairment of the immune system. So one of the things it causes fragmentation of the DNA of the white blood cells, which leads to killing them or causing them to develop mutations. A study a while back found that gliotoxin was found in women with recurrent vaginitis, which is commonly associated with candida, and that women who had vaginal candidiasis had much higher levels of gliotoxin than women without this problem, without candida. Citrinin, the compound right here, is found in several different species of mold, Penicillium, Meniscus, and Aspergillus. Here's Mycophenolic acid. Mycophenolic acid is one that we have to watch out for because it is also used as a drug. And it's used as a drug for people who are doing organ transplants, and it's also used as a drug for treating autoimmune diseases. So you need to alert us if the patient is on one of the, you have to do a history, make sure that the patient is not taking a drug that's used as an immune suppressant, because it will show up. It will, there will be gigantic amounts that will be incorrect. So we cannot accurately test mycophenolic acid if the person is on these immune suppression drugs, which, by the way, are they are made by culturing mold and then extracting the mycophenolic acid from giant vats of Penicillium species. So this is a summary of some of the mycotoxins and showing which ones are characteristic. So, for example, Stachybotrys, one that can cause severe fatigue and can also cause recurrent infections, is commonly produces Roridin E and Varicarin A. So by looking at the type of mycotoxin, you can get an idea of which mold is present. These molds are also always very important in people who are getting chemotherapy, because what happens, the chemotherapy depresses the immunity, and so a lot of these molds, especially Aspergillus, will be problematic on any patient on chemotherapy. So this is a very useful test for patients who are on chemotherapy to make sure their suppressed immune system is not allowing mold overgrowth, which can be more toxic than the cancer itself. Here you see Okra Toxin A, the most common, is being produced by 2 different species. This is not comprehensive. There are probably many different species of Aspergillus that produce Okra Toxin. And you see that Penicillium can also produce Okra Toxin A, but commonly it also produces Strigmatocystin. And in addition to the common molds, mushrooms are also a member of the fungi family. And so poisonous mushrooms are probably poisonous because of the mycotoxins that they produce. So this test could be useful for people who have inadvertently eaten poisonous mushrooms. Some of the mold exposure symptoms may include IgE allergy, and available at many labs, including Great Plains. And there can, in addition to allergy, there can be suppression of the immune system, which is different than just the allergic response. It's due to the destruction of the immune system, like in the case of gliotoxin causing fragmentation of the DNA of white cells. They commonly can cause neurologic symptoms, endocrine problems, cardiovascular symptoms, psychiatric symptoms, and severe gastrointestinal distress. And a common factor is bleeding. So nose bleeding is one of the common symptoms of somebody with mold exposure. The most important treatment for any toxic exposure is to remove the source of exposure. So you want to remove the, if there's contaminated foods, you don't want to eat those contaminated foods. And of course, if it is environmental, you need to find out what is the source. So is it the office? Is it the car? Is it your house? And one thing that's very important is you can't just test one room in your house. I've seen a number of cases where the person has treated or looked at the bedroom and it was negative, looked at the kitchen, it was negative. But what it was is the study, when they pulled back the walls, it was one of those that was a lot of oak paneling. When they pulled back the paneling, the walls were just absolutely drenched with black mold. And so an easy thing, if you're lucky, is just doing the smell test, because there is a characteristic smell. But one of the problems is that the mold impairs the sensation of smelling. So if you've been in a really mold-infested house, you may actually not be able to smell it if you've been in it for an exterior time, because your nose has been decommissioned. One of the important things is that the mold may have set up housekeeping in your intestinal tract. So we've had cases where somebody was in a moldy house in Dominican Republic 10 years ago, but left there 10 years ago and still has very high amounts of mycotoxins, even though the current house doesn't show any evidence. There's no evidence for the office, the car, or the house having any mold at all. Well, in these kind of cases, it can be because the mold has set up housekeeping in the gastrointestinal tract. And if that's the case, you may have to have use antifungal drugs. This is one of the big controversial things in the field. One of the gurus in this area, Shoemaker, doesn't like it, but there's plenty of people who do use antifungal drugs, and I'm one of the ones who thinks it's very important. Sidney Baker had a child with autism, and had complete recovery of the child just by using, the child had extremely high values of the mold markers, and after about 2 months of antifungal therapy, the child had complete recovery. One of the fastest recoveries from autism that's ever been documented. And he did no other treatment except itraconazole, which is also called Sporanox. And he's had a lot of luck with other children with autism as well. So he did no glutathione, no other binders, no cholestyramine, no clay, no charcoal. So the only treatment was the antifungal, and had complete reversal of autism with a marked drop in the fungal markers. So this one and a paper of mine from 20 years ago shows that these fungal markers are prevalent in autism, and that they decline after treatment with antifungal drugs. So these other things can be helpful. So there's no doubt that using oral or intravenous glutathione can be an additional helpful thing. Derivatives of chlorophyll, cholestyramine, a bile acid that inhibits the enterohepatic circulation. So some of these mycotoxins are secreted into the bile and then are reabsorbed cholestyramine prevents that enterohepatic circulation. Clay is very useful, and probiotics are helpful, and charcoal is also very helpful. So one of the things you have to watch out for is if you're using binders like clay or charcoal, you can't give them at the same time as the antifungal drug because you may absorb the antifungal drug. So you want to give it at least like two hours before or after, so that these binders don't remove the antifungal drug. And you also want to take them away from any vitamins because these things would also adsorb vitamins as well. So here's a case study, water-damaged house. And there's the infant in the household that has extreme skin sensitivity. You can see the fingerprints of the father from holding the child. The father himself has cough with phlegm, a very common thing. Of course, now people are going to think you have the coronavirus, but the symptoms of the mold there can be some similarity there. Throat irritation, headaches, sinus problems, severe fatigue and somnolence. So a lot of these, so you'd have to be careful because today a lot of these same symptoms would make you think you've got the COVID situation. In this case, it caused decreased concentration, long-term and recent memory loss, the typical symptom, nosebleeds, reduced libido, hair loss and shortness of breath. In addition, lots of neurologic and psychiatric symptoms, impaired sway balance, so closing your eyes and not being able to keep your balance, reduced grip strength, abnormal vision, abnormal visual field, shrinkage of the visual field, abnormal smell, also a lot of abnormalities in mood, so a lot of depression found. So a wide variety of neurologic and psychiatric diseases can be associated with mold as well. The mother, pretty much ditto the father. The son, age 5, headaches, nosebleeds. It's also, the teacher says that he's having some ADD-like symptoms, having difficulty concentrating. Even the family dog has problems. The 72 skin lesions on the dog. So the dog is closer to the floor, and so it gets a greater exposure than the humans do by being close to the ground. And the lesions the veterinarian said these lesions were called lipomas, which are fatty tumors that are usually not extremely aggressive tumors, but they're very common in dogs. And so what I suspect the reason is because of all the mold contaminated dog food. My own dog, the vet said, oh yes, this is extremely common. A common thing to happen is for, almost every dog she sees sooner or later has these lesions on the abdomen. And probably if you really love your dog, you'll give the dog human food instead of dog food. These were spots, cafe au lait, the dark spots on the back, thought to be associated with a condition called neurofibromatosis. And these are the lesions, the lipomas on the dog's abdomen. They did urine samples and found high amounts of the Okra Toxin. Unfortunately, they did not do the creatinine correction, so that information is missing. But in any case, the father, mother, the daughter, the son, all had the Okra Toxin. Some of them also had Aflatoxins and Trichothecines, and in some cases they were in nasal secretions as well. They were also in breast milk of the mother, the Okra Toxin. It was even found they were in the placenta and umbilical cord, but not in the newborn's urine, but they were very high in the dog's urine. Also, they were elevated in the lipomas. A infectious disease doc in Kansas City found mycotoxins were common in chronic fatigue syndrome, and he found that 93% of patients with chronic fatigue syndrome, he tested 112, and 93% had some mycotoxin, with the Okra Toxin A being the most frequent, and the controls had zero. I'm thinking that the technology used was not quite as sensitive, because we find very small amounts of mycotoxins in controls. Likely the test was not quite as sensitive as the Great Plains test. Abnormalities in visual contrast occur, and there's an online test you can take for something like $10, and what the person does, they get a bar that looks something like a square that looks something like this, and you can, for those people who don't have mycotoxin problems, you can see that the bars are going slightly slanted toward the right. So you would match it up. For those who can see this, it was very similar to the bar down here. And if you get a lot of these wrong, that would indicate your brain isn't functioning well. But unfortunately, it still doesn't tell you it's mycotoxins. Mycotoxins are a common reason for it, but there's many other things that can cause your brain not to analyze pictures accurately. So a compound, a chlorophyll derivative can remove aflatoxin from people who are at risk for liver cancer. So aflatoxins, the reason that they're extremely harmful is they react with the guanine. So DNA has the 4 bases, A, T, C, and G, and guanine reacts with the G part and forms a covalent bond. So, so this covalent bond, you can see here's the guanine by itself, and here's the guanine attached to aflatoxin. And so when it comes time for the DNA to replicate, it doesn't replicate accurately, so it can lead to birth defects and cancer. And this shows treatment and showing the amount of these aflatoxin DNA complexes reduce after treatment with the chlorophyll derivative. So liver cancer is associated with the mycotoxins, and it's thought that this has to do with the aflatoxin reacting in the gene that suppresses cancer. And so this gene, it doesn't work right, and so the person is more likely to develop cancer, because the aflatoxins reacting in the codon 249 of the DNA code, which leads to the cancer suppressor gene not working. And the risk of liver cancer was 60 times higher in people who have the hepatitis B virus infection together with aflatoxin being elevated. So people have that aflatoxin plus hepatitis B 60 times more likely of developing liver cancer. So a major factor in liver cancer. Cholestyramine, again, is useful 2 to 4 grams a day to reduce the hepatic circulation, enterohepatic circulation of mycotoxins. So 4 grams with food twice a day for an adult, less with children. And clay has also been useful. There's a product, New Beginnings at NBN US, which is, it's called GI Detox. It's a combination of charcoal and clay. So a big variety of these products are available online. And clay does help to reduce the incidence of these DNA, abnormal DNA complexes. So mold is not great for the brain. Studies have shown that the Okra Toxin A is damaging to the hippocampal cells in the brain, which are the brain cells that are involved in memory, and they also, it's a place where there are stem cells. So in the past we didn't think that the brain had many stem cells, but now of course it's known that it does, and the Okra Toxin reduces the viability of these stem cells in the hippocampus. Bredesen has published and written a book on treating Alzheimer's and shown that mold is a common cause of Alzheimer's, a treatable cause of Alzheimer's disease. And he has a video of a 52-year-old woman who's starting to lose all her. She has a job in which she's required to do lots of math, but she's forgetting how to do it all. And the thing is, her children noticed that she started losing her abilities when she was at home, but when she traveled and got out of her house, she was much better. And they eventually traced it to the apartment being mold contaminated. And once they cleared it up, she started getting a lot better. There's different biochemical markers that you can look at, but of course all these things are expensive, and but these are part of what is called the Shoemaker protocol. The things couldn't hurt, but you have to look at what is the overall expense. Does it really contribute that much to the ultimate outcome? I don't think it does. Here's a woman, migraine headaches, a high value of aflatoxin, also a high amount of Okra Toxin, not gigantic, but it's probably enough to be causing the migraine headaches. The organic acid test can be very helpful in looking at these. So a number of the markers on the organic acid test are markers for Aspergillus. These are the scientific references. You can see these references are, getting up to almost 100 years old, that Aspergillus products called furans were found with Aspergillus. Here's one of them, 2,5-furan dicarboxylic acid, hydroxymethylfuronic acid, and these were discovered by me in a study of autism found much higher values of these chemicals from Aspergillus in children with autism, and with some, just like Dr. Baker found some improvement. But the therapy that was used in this first research study was nystatin, which is not nearly as effective a drug as the itraconazole in treating the Aspergillus. So a number of these compounds were all significantly higher in children with autism compared to normal controls. You can see here's the autism mean as a multiple of the normal. So virtually all of these compounds were higher in the group with autism compared to controls. And also after 10 days of nystatin, there's a significant decline in the amount of these metabolites, many of which were associated with Aspergillus. Here's a case study of a woman with fibromyalgia, and here are some of the compounds associated with Aspergillus. So the baseline value was 98. After treatment with antifungals went to 0. The furan dicarboxylic, another compound from Aspergillus, went from 67 to 0.6, so about a 99% reduction. And tartaric acid also had a very large decline after antifungal treatment. The studies have found that some of these mycotoxins disrupt dopamine, which could be the reason of the association of mold with Parkinson's disease. Here's one of the case reports, the organic acid. In this case, it's in Spanish. Great Plains presents work, and I think it's like 8 or 9 different languages. So the patient with Parkinson's had high amounts of the chemicals from Aspergillus on the organic acid test. And this is just a close-up of the previous report. Here's a second case, Parkinson's disease, high values of the numbers on the organic acid are 2, 4, 5, 6, and also 9. So 2, 4, 5, and 6 are Aspergillus, and number 9 is a different mold. In addition, I would say the majority of people with significant Aspergillus will have high oxalic acid. So in the past, I had thought that one of the most common reasons for elevated oxalic acid, which can cause kidney stones, was due to diet. But I suspect now that mold problems are maybe the most common reason for high oxalic acid. The second patient also had the mycotoxin test and had very high amounts of Okra Toxin A. We've done a larger study with about 70 or 80 patients, and there's a significant increase. But it's a wide range of both neurologic and psychiatric problems in which there's an issue. So here's bipolar depression. The person has been sick with bipolar for 20 or 30 years, but no one looked at the mold situation. So extremely high amounts of mold markers in this patient with bipolar depression. And the patient also, again, had very high amounts of oxalates. A child with autism, the Aspergillus markers were nearly 50 times the upper limit of normal. So upper limit of normal, 28, the child's values, 1,288. So probably a lot more children with autism could be reversed using more aggressive antifungal therapy together with itraconazole. The problem is itraconazole, about 2% of the cases there can be elevated liver enzymes after a few weeks. And so you can't be a nervous Nelly. You have to accept that 1 out of 50 patients, you may have to deal with elevated liver enzymes and discontinue it. But the upside is very large. You can see this, the child with the very high mold markers had gigantic amounts of oxalate as well. Oxalate is, this shows a culture on Petri dish of oxalate crystals formed in Aspergillus. And you can also see oxalates growing on this mold that's growing on a tree. And I think I'm running out of time. So, but actually I've only got a couple more, so I'm just going to run over maybe a minute or two. So Aspergillus infection of the digestive tract has been reported, and when it occurs, there's huge amounts of oxalates formed, and it was found that in the person who had a gangrenous appearing foot, there were high amounts of oxalate in the area of the foot and which Aspergillus was found. So to summarize, there are markers of the most common mold genus Aspergillus are found in the organic acid test. Almost 100% of samples positive for furans are positive for Okra Toxin A, but the reverse is not true. So if a person is negative for the furan compounds, it does not mean they don't have other kinds of mold that might not be picked up on the mycotoxin test. But if the person is positive on organic acids, I mean, if you could probably just treat for the mold problem without doing mycotoxins, although the organic acid obviously test is not nearly as comprehensive as the mycotoxin for other strains of mold. And one of the most important things is people will do the therapy, but then don't repeat the test. So one of the most important things I would say is after treating, so the first thing is get rid of the mold. Once you've got rid of the mold in the household, which is the most common thing, repeat the test in a month or 6 weeks to know if your treatment has worked. If it hasn't worked, you need to change your therapy and do something else. So that's the most important thing. So thank you. Enjoyed it. And now we should have Dr. Neil Nathan appearing.
Excellent. And if we can get my presentation up, I'm almost there. Good evening, everybody. There we go. Okay. Okay. Good evening, everybody. I hope you can see my slides here. I may need to move my picture. to get out of the way a little bit. Let me move this out of the way. Okay. I'm going to put myself in a corner. Okay. Good evening, everybody. I'm a clinician, and I specialize in helping patients with complex medical problems, of which mold and Lyme and several other things are some of the commonest things that I see. So this presentation will dovetail and piggyback on Dr. Shaw's presentation. So we're going to talk about a practical approach here. So my focus is going to be on what you can take back to your practices immediately in order for you to both improve your ability to diagnose mold toxicity and to treat it. So I have no financial ties to any laboratory, medication, or supplement that I'm going to be discussing in this presentation. And I want to comment that the science of the diagnosis and treatment of mold toxicity is really in its infancy. So this presentation is an attempt to synthesize the information that we now have so that we can help you to diagnose and treat better. I also want to comment that I basically get referrals from other physicians of their most toxic, most sensitive, most difficult patients. And so with that in mind, I'm going to focus on those with the intent that if you can treat those patients, you can treat those who are not as sick much more easily. And I typically will put into my presentations a few beautiful pictures. This is a rhododendron, Mendocino gold, grown in our area, in fact, in my front yard. So today we're going to focus on mold toxicity and how to work with it. I want to emphasize that each patient is genetically and biochemically unique. So each patient will require their own approach. I've been asked repeatedly to create an algorithm to do this, and I've repeatedly refused to do so because I really want you to view each patient uniquely. There isn't one way to approach this, and as you work with patients, you're really going to get the feel for that. So when we talk about mold, we tend to focus on fungi and fungal structure. But when people are reacting to mold in their environment, they're reacting not only to fungi, but also to actinomycetes, mycobacteria, volatile organic compounds, and a whole host of other proteins and proteinases in the environment, which is like a irritating inflammatory soup that trigger these reactions that we're going to talk about. I also want to emphasize that for many years in the mold world, all we ever talked about was mold allergy. Now we're talking about mold toxins. Keep in mind that infections with mold occur, but true infections that are systemic are extremely rare and they're life-threatening. That's not what we're going to be talking about. However, we're also going to be mentioning, as Dr. Shaw alluded to, that colonization does occur. This is not a system.
Dr. Nathan?
Okay.
I'm sorry, I need it. If they're saying they can only see you on the screen. I don't see you. Can you turn off your webcam?
I'm trying to figure out how to do that.
Okay. If you can.
How about now?
Okay.
It's not staying up.
That's good. Yep, we're good. Thank you.
Okay. Okay. Now you have to look at my mug. Sorry about that. Now, mold toxicity directly triggers or influences a host of other conditions which you've got to be aware of because it's rarely just simply mold toxicity. Mold toxicity triggers mast cell activation, secondary porphyrias, methylation issues, reactivation of viral, bacterial, and parasitic infections, and really important, underappreciated, is it triggers limbic dysfunction and vagal nerve dysfunction. which are key to interfering with patients' ability to take the things they need to get well. I'm sorry, now I can't forward this properly. If
you can't move forward, okay, go back to how it was. It's fine.
Go back to,
yeah, before you moved your webcam.
okay.
Yeah.
So I'm going to take this off. Is that better? Let me see if this works.
So
nope.
We can
nope.
see.
Still.
Yeah. Can you? Let's see. You
Sorry.
No, it's okay. Let me see here.
Well, I can.
What
perhaps
did you press to make it change?
Let me try this.
Okay.
Nope.
Okay. So you can't move it forward.
No, I can't move it forward or backward. I did until now. I'm
Okay.
not sure what changed.
Can you stop where you are and then try to reload it?
Oh boy.
There we go. Okay, so click on that one on the left. There we go. Now,
okay. I'm sorry. It's not.
It's okay. So move your mouse down to the right where you maximize your screen, like we did earlier.
I'm sorry. Move my mouse.
Yeah. Move your mouse to the very right of your screen.
Okay.
Down in the orange and maximize it like we did earlier. Nope, over. There's a go to the left.
I clicked on it.
There we go. That should work.
Ah, there we go.
Okay.
Okay.
Okay, I'm signing.
Yeah, giving the lecture's not hard. The technology is for me. Okay. So coming back to it, we're going to look for and treat all of these conditions that we can find. But it's also important to get into timing, and I'll get into that later in my presentation. We need a new model to understand mold toxicity. It is not as simple as you have mold and I will give you a binder or I'll give you an antifungal. Mold toxicity affects virtually every organ system in the body. And these are the models that we have used to help understand this in its complexity to allow us to move forward. So we're not going to be talking about it today, but I'm really going to encourage all listeners to look up the cell danger response as the most profound model, the Rich Horowitz 16-point differential diagnosis model, Dr. Dale Bredesen's 36-point recode model, and Dr. Richie Shoemaker's biotoxin pathway. Okay, quick overview. I'm going to go through this quickly because I want to get more clinically involved. Dr. Shaw did cover this to a certain extent. In genetically susceptible individual, mold toxicity is the way mold toxin is processed or not processed. Okay, so in our environment, the question comes up, are all molds toxic? And the answer is no. There are literally, I'm giving this presentation looking out my window at the redwoods of Northern California. So there are 1,000 species of mold out there. Not all of them are toxic. In fact, only a few are. And Dr. Shaw mentioned most of them. Stachybotrys, Penicillium, Aspergillus, Ketonium, Fusarium, Alternaria, Wallemia. So we're exposed to hundreds of these out of doors. However, these don't generally get us into trouble. Number one, most of them are not toxic. And number two, most of them are not really in our face in terms of giving us these symptoms. We get into trouble when water-damaged buildings occur. And I know Dr. Shaw talked a good deal about mold in food. And while there are epidemics of unusually toxic food that surface from time to time, the vast majority of people that we see, their issue is exposure from a moldy building. Keeping in mind that mold toxicity makes everything else that the patient is experiencing worse. It makes Lyme worse. It makes patients with multiple chemical sensitivities, electromagnetic exposures, food allergies, autoimmunity. All of these are made worse or caused by mold toxicity. So this is a sign that sits on the outside of my building in which so many of our patients become chemically sensitive from their exposure to mold that we really have to encourage them to not wear any scents. A single patient wearing a scent can affect the entire practice that walks into that building for the rest of the day. Okay, now, Dr. Shaw went over this, but I think I might go over this in a smidge more detail. Mold toxins will cause a vast array of systemic, multi-system issues. And all of these may occur, or a few of them may occur. But keep in mind, when you're trying to discover in your complicated patient, someone who comes in, they're not feeling well, and nothing you've done or your colleagues have done have helped them. These are the things you want to be looking at. After I go over them fairly quickly, I'm going to focus on a few symptoms that are literally pathognomonic to mold that you really want to start looking at. So we've got weakness, fatigue, muscle aches, and muscle cramps, unusual pains, often described as ice pick or lightning bolts, headaches, sensitivities to light, blurred vision, chronic sinus congestion, cough, chest pain, shortness of breath, abdominal pain, diarrhea, joint pain, tendinitis, cognitive impairment. Dr. Shaw presented several cases of people with what looks like Alzheimer's disease that get cured when you treat their mold toxicity. Skin sensitivity, mood swings. Again, most of my patients with mold toxicity have difficulty with emotional upheaval, including mood swings, appetite, difficulty with temperature regulation, numbness, tingling, especially non-anatomic, which I'll talk about more, vertigo, dizziness, hormonal issues like impotence and menorrhagia, nausea, vomiting. So let's look at the symptoms and the presentations that really, when you see them, you really should be thinking mold. Fibromyalgia, chronic fatigue syndrome. Okay, click on that. Okay. In the paper quoted by Dr. Shaw, Joe Brewer in 2013 did this wonderful study in which he looked at 112 patients with chronic fatigue syndrome. 93% had excessive amounts of toxin, mycotoxin, in their urine. If you have a patient who's been given a atypical diagnosis of MS, rheumatoid arthritis, Alzheimer's, or Parkinson's, think mold. If you have a patient with shortness of breath and the diagnosis of asthma, but their pulmonary function tests are absolutely normal, or chronic sinusitis, think mold. In the psychiatric field, anxiety, especially if it's unrelated to stress, depression, depersonalization, cognitive impairments, mood swings, OCD, think mold toxicity. Unique symptoms, if someone tells you they have electrical shocks or ice pick pains, or they're having numbness and tingling described as paresthesias, but it's in places that you don't normally see that, be it their chin, their nose, the central part of their chest, places that neurologists say you can't have paresthesias in those areas. Well, actually you can. This is an autonomic nervous system issue. And if you get unusual paresthesias, think mold. Key symptom. If a patient tells you they are experiencing intense vibrations that are not visible internally, this is almost always mold toxicity or Bartonella. And mold toxicity will cause an increased sensitivity to everything. Sensitivity to light, sound, touch, food, chemicals, and EMF. So, given a history that makes you begin to suspect mold toxicity, the next step is to confirm that diagnosis. There are a variety of ways of doing it, which Dr. Shaw alluded to. The one that I think is the most accurate and useful and financially inexpensive in the long run is urine mycotoxin testing. You can also do visual contrast testing, which we talked about. Dr. Shaw also mentioned that Dr. Shoemaker's biomarkers, which consist of things with funny names like TGF-beta1, C4A, MSH, VEGF, VIP, MMP9, can be helpful, but they are much less specific, as I'm going to show you, for the presence of mycotoxin. And we'll also talk a little bit about genetic testing and markons. So, my experience, having treated several thousand people with mold toxicity, is that the urine mycotoxins have revolutionized our ability to make a specific diagnosis and also to really give us a blueprint for how to go about treatment. The markers, which we mentioned, suggest the presence of an inflammatory illness, but they do not tell us whether the cause is either toxic or infectious. So, why start with the urine testing? Because it confirms the diagnosis and it tells us what treatments will be most effective. There are two main testings that are available. There's ELISA testing. The main labs that do it currently are Real-Time or Vibrant Health. And then the Great Plains has pioneered the use of the liquid chromatography mass spec. There's a difference between these testing. It's really important that you understand that these tests give us different information. Mass spec is theoretically more accurate and reliable, but it's much more specific about what's being measured. What it tells you it measures accurately. ELISA testing is a little different. It may not only measure the toxin, but it also can measure their metabolites, so it's a bit more semi-quantitative. So the real-time test measures many of the same things, in fact, that Great Plains test measured that Dr. Shaw reviewed with you all. And this is kind of what their test looks like. The Great Plains test was reviewed in detail by Dr. Shaw, and I don't need to go over these again. And it looks a bit like this. Well, what I get asked a lot is which test is better? And I want to emphasize, they don't measure the same thing in the same way, so you really can't compare it. I find in clinical practice that they both give me excellent and useful information, and if possible, I do both. And although they're expensive, the amount of medical care that many of these patients need is exceptional. Many of the patients that I see have had $50,000, $100,000 of medical tests and care before they get to me, and no one's ever looked at their mold toxins. So for basically $300 or just about, you can get a really good test, which is extremely monetarily valuable and useful. So if you're going to do these tests, it's very important that you understand that mold toxic patients usually have a compromised ability to detoxify. What that means is your first test may not pick up the full range of what's actually in their body. Translation, they may have a boatload of toxin in them and they can't excrete it into their urine where it will show up in the urine. So I typically find that these patients benefit very much from several types of challenge testing. For all patients using some form of sweating, like a sauna, a hot tub, or a hot bath, the night before they collect their urine is extremely helpful in giving more accurate information. I also use, for most patients, glutathione. Dr. Shaw has found that he's got some concerns that glutathione may interfere with the assay that Great Plains uses. I have done the glutathione challenge with hundreds and hundreds of Great Plain tests, and I'm not sure that I see that particular issue arising. Okay. Be careful with the provocation process. If you do use glutathione, the reason we're using it is that it can mobilize toxin, getting it out of the body. It can do it so quickly that a small dose of glutathione for many patients, especially if they're sensitive, will actually make them worse because it will mobilize toxin faster than they can process it, and they will get worse. So be careful. If you are getting any reaction from glutathione in your patient, collect the urine then. Don't keep going for any period of time. Again, I want to emphasize that anything that mobilizes mold toxins may inadvertently pull more toxin to the body than it can deal with. So you got to be careful with that. And this holds true of treatment, as we're going to get into as well. Any positive test that you have may be significant. I'm going to go over this into a lot more detail now to help you understand what you're looking at. As I said, the initial testing numbers may not reflect the total load. Many of our patients will have mildly elevated levels initially, enough so that we can make the diagnosis. And the majority of them, as they get better and you retest their urine, their numbers will go up. This does not mean that they're worse, usually. It usually means that now they're able to excrete the toxin into their urine to a much greater degree. And those numbers probably represent what they originally had, now that you've improved their inability to detoxify. So I typically call the first numbers that I get tip of the iceberg. Okay. So our urine testing reflects not only the presence of the mycotoxin, but the body's ability to mobilize and release those toxins. So when you look at your numbers on your tests, it's really important that you align those numbers with the clinical picture for it to make sense for you. Now, let's say you do your testing and you repeat the test and you get higher numbers next time. So let's go over what that might mean. For some patients, it means that they're being re-exposed to mold. For some people, it's what we just talked about. Their ability to detoxify has improved. For some patients, it means you're pushing the binding too much. For some patients, you're actually killing the mold too quickly for their own body using antifungals. And last but not least, molds make mycotoxins in response to a threat. It's energetically expensive for them to do so. So if you are actively threatening the mold by giving them antifungals, you may raise their mycotoxin levels, so it may be simply a manifestation of your treatment. Okay. Here's an article on amphotericin B enhancing the synthesis and release of gliotoxin, which makes my point. Let me give you a quick example on how you look at it. I had a 60-year-old woman with long-standing Lyme disease who had gotten about 70 to 80% better. However, because she wasn't fully improved, I checked her for mold toxicity, and she had very high trichothecene on her initial test. I asked her to go slow on increasing her binders, which I do with everybody. But as many patients do, she increased her binders far more rapidly, and she got much worse with severe exacerbation of her joint pain, worse fatigue, and work cognition. So I'm going to show you her initial tests, and then I'll show you her marked increase in toxin levels just from taking too much binder. So this is a real-time test which shows a trichothecene level of 1.21, which is about 6 times over the upper limit of normal. With no treatment other than binders, she now has a positive Okra Toxin level, a positive Aflatoxin level, and a massive increase in trichothecene. So how do we distinguish an increase in toxicity from improved detoxification? In most cases, it's fairly simple. She was getting steadily worse on treatment. So very simply, we stopped her binders. for several weeks. It can sometimes take a few weeks. Her exacerbation completely resolved, and we got the dose of binders right. She steadily improved and actually got completely well. So sometimes you'll get a negative test, even though the patient gives a history of clear exposure to mold in their home or work, all the symptoms that you associate with mold toxicity, but they've got a negative test. So sometimes you need to treat these patients empirically. You may not know how exactly because you don't have the information you need, but you can do a generic treatment program, which we'll go over in a bit. Now, some people have claimed that everyone has mycotoxins in their urine. Now, this would, if that were true, it would make urine testing not as useful as we think it is. However, Great Plains recently did a wonderful study, which was published in the Townsend Letter, of 82 controls and 103 mold patients. Now, this did show that 51% of controls did have okra toxin in their urine. The other toxin levels were essentially trivial. However, it's important to note the amount of okra toxin that was present in the controls and the patients. As Dr. Shaw said, the most common toxin, 85% in these patients, had okra toxin. Their average level of okra toxin was greater than 18. However, in the patients who were controls, the average level was only 1.6. So when you look at these tests, any okra toxin level over 7.5 or 10 is almost certainly significant. So while it is true that many controls will have small amounts of toxin in their urine, particularly okra toxin, in no way does this invalidate the test. In fact, the opposite's true. Any significant amount of okra toxin and any other toxin you see on these tests is almost certainly meaningful. Let's say you got a negative test. What does that mean? Well, it might mean the patient's not mold toxic. Maybe your initial assumption's wrong. It might mean, and I've seen this in several dozen cases, the patient's ability to detoxify is so compromised they can't excrete toxin. These are the people that you treat empirically. They start to get better. You repeat their testing, and by gosh, their mold toxin levels are quite high on a repeat test. Another possibility is that the test may not measure the toxin that's causing symptoms. For example, we don't have a test for Wallemia yet, and so if you had that toxicity, we wouldn't pick it up by testing. And occasionally, we just don't get an accurate result. So, how do we make the diagnosis of mold toxicity? I hope I've made for you a case that urine mycotoxin testing is by far the most accurate way of going about it. Another approach, which is crude, which Dr. Shaw referred to, is visual contrast testing, which I'll mention. I also mentioned the biochemical markers, which measure inflammation, but they're not specific for mold. This is kind of what a visual contrast test looks like, which Dr. Shaw told us about. And it's graphed out this way so that basically you're looking at rows C, D, and E along the bottom. And if the patient can't see those below the lower line, it's an obvious failed test. Keep in mind, however, that a failed test reflects not just mold toxicity, but also Lyme disease, mercury toxicity. So while it is helpful to monitor things, it is not as specific as we need. Again, as I mentioned, the other markers such as TGF-beta1, C4a, MMP9 measure inflammation, which can be helpful, but they don't tell us what process is causing this inflammation. So my bias is that urine mycotoxin is far more accurate in helping us to know when treatment is not only going on, but it's infinitely more accurate to tell us when we've fully treated our patient. You can't really know by any of the other testing that treatment's been completed. When the urine mycotoxin test comes down into the normal range, now you know that you've succeeded. I'm going to mention briefly MARCONS, which is multiple antibiotic resistant coagulative negative staph. Dr. Shoemaker has pioneered the thought that this is extremely important in treatment, but after having treated this for many, many years and not noticing any significant clinical improvement, I no longer think that this is an important issue. Many, many other mold clinicians have agreed with me, and I'll bring this up as a controversial issue. Second, Dr. Shoemaker has put a great deal of value on the use of genetic testing using the HLA-DA markers. However, again, I have not seen a correlation, and increasingly my colleagues are not seeing a correlation between having those genetic predispositions and the ability to successfully treat the patient. Many of my patients with supposed dreaded genes respond beautifully to treatment, and many of my patients who don't have any genetic predisposition, supposedly, are very hard to treat. So I don't find that useful as something to distinguish who we can help and who we can't help. Okay, quick turn, that's my front yard. So take a little break from this onslaught of inflammation and we'll continue. So the basis of treatment, as Dr. Shaw told us, number one, you've got to evaluate the patient's home and work environment and either remediate it or the patient's got to get out of that environment. They will not get well if they are continually exposed to mold toxins. Then you need to use the correct binders to treat the mycotoxins that are present. And lastly, if that is not sufficient, then you need antifungal treatment if they have colonized. To test your home, a couple of basics. One of the major tests that's used by many home evaluators is what's called air testing, where they take a device, they put it in the center of the room, and they collect spores in the center of the room. It is the standard, the gold standard, if you will, of the building industry to let you know if there's a moldy building. It is also the most inaccurate test to tell if there's mold toxicity. The reason for that is these spores are heavy. They have weight. They do not float around in the center of the room. So if you are a landlord and you want to prove to your tenant that they don't have mold toxicity, great test. If you're a building contractor and you want to prove that no, there's no mold, great test. But if you're a patient and you're suffering with possible mold toxicity, not a good test. So there's several other ways of doing it. One that I like a lot is to use what are called mold plates, which are simply petri dishes with a mold growing media. You simply open the plate, put it on the floor of the room for 2 hours, put the top of the plate back on, and then see if something grows. If it is, you can test those plates for mold species and find out what's growing there. If they're mold toxic, it really helps you to know, yes, you've got a problem. A bit more accurate but more expensive is what's called Urine Testing, where you either use a Swiffer or vacuum 5 grams of dust from that room and send it through Urine Testing, which uses PCR technology to measure 36 different, especially toxic mold species. If there's any question, get an independent environmental evaluation. Remediation may be really expensive, and I've got to tell you, sometimes it doesn't work. This is the Hurts Me Too system developed by Dr. Shoemaker, available on his website, survivingmold.com, which you can take your Urine test, and using a point system, we can award points, and any score over 15 is definitely too dangerous for a patient to be in the building. 11 to 15 is borderline, and 11 means you're probably okay. Okay, and this is my backyard. Let's talk about binders now. So what we have learned is that specific mycotoxin are bound best by specific binders. This allows us to take the test we've got and be precise about how we're going to bind it. So with Okra Toxin, the most common binder, the best binder, the most common toxin, the best binders are cholestyramine, or Welchol, its cousin, and activated charcoal. For gliotoxin, the best binders are bentonite clay, NaC, and the good probiotic yeast, Saccharomyces boulardii. For trichothecenes, bentonite clay, activated charcoal, and chlorella. For aflatoxins, the same. For zearalenone, bentonite clay and Saccharomyces boulardii. And as Dr. Shaw shared with us, there's also a paper showing that cholestyramine is helpful. For aneatin B, clay and Saccharomyces, we do not know specifically, at least in the medical literature, what the best binders for ketoglobulin are. But by clinical experience, we can completely eradicate it by using a smorgasbord of other binders. If we use clay, Saccharomyces, chlorella, and cholestyramine, the ketoglobulin goes away. So although there's no research showing that, clinically, that's what we see. I need to explain a little bit about binding, because binding connotes tightly bound so that your fingers interlocked aren't coming apart. But that's not really what's happening here. Activated charcoal, for example, doesn't really bind, although we use that word. It adsorbs or adheres to the bound material, like charcoal. It's kind of more like static cling. So with binders, be aware that they are not tightly binding it. And I'll come back to this in a few minutes to help you understand that if you use too much binder, it may get you into trouble. So when I start with my binders, I choose first the binder that will affect the mycotoxin that is in greatest excess on the report that I'm looking at. Okay, it's very important to assess your patient's sensitivity or strength of constitution to decide on a preliminary starting dose. If you start too high, you're going to make your patient really sick. Again, as Dr. Shaw mentioned, all binders should be taken away from food or other supplements by about 2 hours on each end. They can be taken just once daily, altogether. Usually 3 in the evening is my preferred method. Saccharomyces it can be taken with food. So I'm going to distinguish in these slides sensitive patients versus constitutionally strong patients. Sensitive patients are the ones that come in and tell you they tried one chlorella and it threw them under the bus. They tried one charcoal, threw them under the bus. They took a normal recommended dose of cholestyramine, which is 4 grams several times a day, and they got sick as a dog. So when a patient is telling you that they've tried these, or if they haven't tried them, and you start with modest to high doses, and a patient gets sick immediately, it's super important that you stop the binder as soon as they get sick until those symptoms ease off, and then go back to lower doses. So I'm going to give you 2 different dosing strategies. In the patients that I see, who are almost all sensitive, we would start with 1/16 of a teaspoon of cholestyramine once a day. If you've got a patient who's got a strong constitution, you can start with 1 or 2 teaspoons. Please use compounded cholestyramine, because the stuff you can get from pharmacies has either sugar or Splenda, both of which are not really helpful. The usual dosing from a compounding pharmacy when they make it up is 4 grams per scoop, and then you can dose it as the patient can handle it. So with Okra Toxin, if you see it, if the patient can't handle cholestyramine, try Welchol. Comes as a 650 milligram tablet. Start with 1/4 of a tablet once a day, bump up as the patient can handle it comfortably. If they've got a strong constitution, they can take 1 or 2 tablets up to 3 times a day. With charcoal, start with a low dose charcoal capsule, like 250 milligrams, and start with 1/4 of a capsule. ease your way up. With stronger patients, you can start with a stronger capsule, 500 milligrams, and take between 1 and 3 a day. For gliotoxin with Saccharomyces, if you've got a sensitive patient, find a lower dose, like 3 to 5 billion units per capsule, and start with a quarter of a capsule and work up. Stronger patients, 5 to 10 billion units, work up to 1 with each meal. For clay, I'm a very big fan of liquid bentonite clay to start sensitive patients, starting with 1/8 to 1/4 of a teaspoon a day. With patients with stronger constitutions, I like a product called Metaclay, where they can take 1 working up to 3 a day. NaC, start at 500 milligrams once a day, and you can work up to a higher dose later. For treating Cycazines and Aflatoxins, you can use the doses of bentonite and charcoal that we talked about, and then glass-grown chlorella tablets. Sensitive patients, 1/4 of a tablet once a day. With less sensitive patients, 1 to 3 tablets daily, or even twice a day here. Keep in mind that on many of the chlorella packaging, it will say take 15 tablets twice a day. You will have very few patients who can do that. Please don't do that. So, issue with binders. They can and do mobilize toxins sometimes faster than a compromised detoxification can take it. Go slowly with the binders. Any patient who tells you that they are worse with any dose that they're taking, got to change the dose. You got to get them to stop it until the symptoms go away, or they're just going to get more toxic. Most of the binders are constipating, and if you can give the patient additional magnesium and vitamin C, that will usually take care of that nicely. Take a break from this information with a little look at meadow foam, one of the spring flowers that grow up here on the coast. Okay, what about diet? If you eat a high carb diet or sugar or fruit, you're going to be feeding the mold that is probably growing and the candida that is probably growing in your gut. So the basic diet is a high protein, low carb diet. 20 to 60 grams of carbs. Not everyone can handle that. Some people need to go higher. Most of my patients currently use a keto diet. Does yeast that is present in cheese, vinegar, and mushrooms matter? In my clinical experience, it doesn't, but you will see many people saying you've got to avoid that. As far as I can tell, there isn't candida or fungus in those materials to any appreciable degree. Speaking of appreciable degree, I want to comment on the amount of mold toxin in food. So although there are many papers in the medical literature showing that food that is contaminated, badly contaminated, can cause a great deal of harm, the amount of mold in most of the foods that reaches our shelves is quite minimal. And recent research, which I'm going to go over in a minute, suggests that it may not be as big a player as some people suggest. Most of the mold you see is going to come from a water-damaged building. So there is some mold that is potentially present in dried fruit, aged cheese, mushroom, coffee, beer, wine, processed meat, and some fermented fruit. Okay. Is it significant? I did a study with the Great Plains Lab last spring on 8 patients to test this hypothesis. Now, what they did is that for 10 days, they avoided all potentially moldy foods, and then we did a Great Plains urine mycotoxin test on them. Then we had them pig out on all of those foods for the next 10 days. And then we repeated the test. The results were somewhat surprising. Of the first 8 patients which we ran, 7 patients' mycotoxin levels went down eating supposedly potentially moldy food. 1 had a slight increase in okra toxin level. Obviously, we've got to do more studies on this, but I'm going to suggest that mold toxins in food is not the primary source. Once the binders are up and running, then we turn to doing treatment for antifungals. I typically remeasure urine mycotoxin levels 3 or 4 months after the binders are fully up to see how people are progressing. Now, if they're getting really well on just binders, we do not need to consider antifungals. But if they're not getting better and the urine mycotoxin tests are showing very little improvement, we need to add antifungals. And I want to add here that although Dr. Shaw presented the case that Sid Baker gave us, I want to urge patients, practitioners, to not use antifungals until the binders are fully up and running. If you start giving antifungals, there is a high risk of a serious die-off, which will make your patient really sick for anywhere from several weeks to a month or more. So if you're going to use antifungals, please get the binders up and running first. Okay. I usually begin my antifungal treatment in the sinuses, followed with a colloidal silver product. Argentin 23 is my favorite. And then I will add an antifungal and a biofilm dissolving agent. Okay. The specific antifungal, and I'm going to give you this in more detail right now, should be tailored again to whether your patient is sensitive or constitutionally strong. So constitutionally strong patients can usually start on amphotericin B nasal spray, starting with 1 spray or atomizer once a day and working up to twice a day. Sensitive patients should probably start on nasal nystatin. For patients intermediate in reactivity, I will start with itraconazole 1% or 2% ketoconazole nasal spray. Now, one of the things we've learned is that mold, fungus, and candida make a great deal of biofilm. This is basically a type of polysaccharide glop that coats the microorganisms, shielding them from antifungals and from the patient's immune system. So we have learned that it's very important to add biofilm dissolving materials to what we're treating with. So I typically use a compounded nasal spray containing EDTA with an atomizer, or what used to be called BEG spray. I've eliminated the G, which is gentamicin, and I typically use BE spray to treat the biofilm and the nasal spray concurrently. I then turn my attention to the gut, and I start Argentin 23 orally, 1/2 to 1 teaspoon a day, followed by, if the patient has gliotoxin or on their O test, evidence for an elevated arabinose, candida is very likely. Most of my patients have candida also. So I will often, but not always, add nystatin, 500,000 units, starting with a low dose once a day and working up to 4 times a day. I will then add Sporanox, which is also called itraconazole, 100 milligrams. For my sensitive patients, I will start with 1/2 to 1 Sporanox every 2 weeks. For a constitutionally strong patient, once or twice a day. I'm now using more and more amphotericin B as an oral solution. Keep in mind that although it has a terrible reputation, amphotericin B is not absorbed through the mucosa, and it does not have systemic toxicity. So you can use it in small doses in the gut to help remove your fungal elements. 2 products that I like to dissolve biofilm in the gut are MCBFM from Beyond Balance or Interphase Plus from Claire Labs, 1 or 2 capsules a day. Here are some of Dr. Brewer's papers which go over some more treatment. I would also mention that there's a couple of probiotics which have been statistically shown to help remove mold or protect the body from mold toxicity. The question has been raised by using these antifungals are we not causing an increase in antifungal drug resistance? Neither Dr. Brewer nor I have seen any evidence of this in the several thousand patients we've treated, and HHS did a position paper on this several years ago, which shows that it is really quite rare. What about allergy? Now, some patients are allergic and toxic. Now that's a problem, because if the mold is colonized and it's in their body and they're allergic to it, you need to treat the allergy as well as get it out of their body. The American Academy of Environmental Medicine teaches excellent courses into approach the allergy component. A couple of other useful treatments which we use as well include Pro-Myco, Mycoregan, Tox-Ease from Beyond Balance, A-Fung from Byron White, Biotoxin Binder from Cellcore, and Biocidin Nasal Spray. Intravenous phosphatidylcholine is extremely helpful, especially for sensitive patients, to help heal their membranes and to help gently remove toxins from those membranes. Ozone and insufflation of the sinuses can be helpful as well. This just shows kind of how it's done. That's an ear device to put it through the ears as well. Low-dose immunotherapy can be helpful. Transfer factors, especially transfer factor Enviro, has been specifically designed to help improve the immune system's ability to deal with mold toxicity. For really sensitive patients, I mentioned at the beginning, but I want to emphasize it, many of them will not be able to take binders or antifungals until you quiet their inflamed limbic system and polyvagal nerve areas first. The same way many of these patients have developed mast cell activation, you may need to treat those things first before you can even begin to treat these conditions. So also, the mold toxin affects the pituitary's ability to regulate hormones. Most of my patients should have their thyroid, adrenal, and sex hormone evaluated and treated early on. Keep in mind, mold toxin levels fluctuate, and you're hitting a moving target. So let me do one quick study, and then maybe we can open this up for questions. Just to give you an example, I had a 20-year-old woman who came to me a number of years ago. She was referred by the Cleveland Clinic with a history of severe recurrent syncopal episodes, 10 or 20 a day, associated with extreme fatigue, cognitive dysfunction, anxiety, paresthesias, my whole body gets paralyzed, dizziness, markedly exacerbated by exposure to heat, and POTS, which was diagnosed at Johns Hopkins despite having a negative tilt test. Complete repeat neurological workup was negative. Symptoms had begun 5 years prior, and she slowly, insidiously worsened. She did have history of a tick bite and mold exposure. Her Hygienics Western blot showed a 4+31 with a positive epitope and a +8393. However, the advanced lab test, which is not currently available, showed no growth. So the treatment she had for Lyme may at some point have been sufficient. Now, in September of 2015, a real-time mycotoxins test showed a trichothecene of 0.30, with the upper limit of normal being 0.20, meaning just slightly elevated. As I said, many of these patients, that's the tip of the iceberg. So her clinical symptoms matched. She did have history of mold exposure, and she had a slight increase on testing. I started treating her very, very gingerly. Since trichothecene was her primary toxin at that point, I started her on chlorella. We started with a quarter of chlorella. To show you how toxic patients work, it took until December, from September, to work up to 1 a day. Her glutathione level, which we measured at that point, was 2.9, which is quite low. By January, she was up to 2 chlorella a day. Keep in mind, even on tiny doses of just chlorella, her syncopal episodes had markedly reduced, so that by January, they were down to only a few a day. Now, these syncopal episodes were considerable. When she first came into my office, her mom sat right next to her, vigilant. And I consider my reflexes pretty good, but this young lady literally just fell over with no warning. And if her mom didn't catch her, I would not have been able to. And she did this repeated during our first visit. Okay. But after she was able to tolerate a little bit of chlorella and was getting better, eventually we added some intranasal nystatin, some Argentin 23, and beg spray. By March 1st, she was down to only 1 or 2 of these episodes per week. Her energy and cognition had improved enough that she successfully resumed online college courses. And basically, she was homebound when she first came to see me. By March, we repeated her mycotoxin testing, and now we're going to see what she really had. Now we see an elevated Okra Toxin level, an elevated Aflatoxin level. The trichothecene had doubled, and Gliotoxin, which was not available earlier, was huge at 7.76. Now, although her electrical activities and tremors were still present, they were less. Her episodes were rare, mostly related to stress. She was then able to take on a part-time job as a sales assistant in addition to completing her online college courses. This just shows her follow-up test. As I've continued to follow this patient as of Christmas 2019, she graduated from college and had begun graduate school. She's had a few flare-ups when exposed to mold in different environments, nothing like her initial presentation. Basically, she's got her life back. So I'm going to scoot through some of these here. A couple of last points and we'll open this up for, okay. When you start treating these patients, start with the pathology that explains the vast majority of their symptoms. Usually, this will be mold toxicity or Lyme. If you have both, start with mold. Remember that you may have to detoxify the patient and address limbic, vagal, or mast cell function first. Okay. All righty. Please do not use cut corners or use shortcuts. I've often seen a lot of patients who listen to my lecture, a lot of practitioners, and they think, oh, I don't need that, or I don't need that. For treatment to be optimal, you need to bind all of the toxins present, and you need to treat the fungal candida reservoirs for long enough to get negative testing, and you'll be much more successful. Okay, so if you would like to know more, let me recommend to you my book published about 1.5 years ago, which contains all of this information and a good deal more. It's simply called Toxic: Heal Your Body for Mold Toxicity, Lyme Disease, Multiple Chemical Sensitivity, and Other Chronic Environmental Illness. I am available for consultations with practitioners and patients. I've got a newsletter and a mentorship program. And so if I can help you to get better at this, I am very eager to do so. So thank you very much for your attention. And now we can open this up for questions.
Dr. Nathan, so how we had decided to do it, because there are hundreds and hundreds of questions, was I'm going to send them to you and Dr. Shaw after this webinar, and then I will send the answers to the attendees when I get them. Is that okay with you? Dr. Nathan?
Okay. Sorry. Is everybody out there?
Yeah, Dr. Nathan, can you hear me? Dr. Nathan? Okay, we're going to go ahead and stop the webinar. I have all of your questions and I will get them all answered and I will send you.
Hello, anybody out there?
Dr. Nathan, we're going to go ahead and end the webinar. I don't think, can you hear me?